afternoon for our Teach Educational rounds on increasing the likelihood of quit success, integrating a mood intervention into smoking cessation programming. Thank you for everyone who's joined us already. If you are interested in obtaining a letter of completion for this Teach Educational rounds, please make sure that you've registered for the webinar and completed the pre-learning assessment. You are currently signed in to view the live webinar using your first and last name because that's how we track your completion. And finally, after the webinar, I will be sending out an evaluation and post-learning assessment, so you'll have 1 week to complete that. Remember that these webinars are being live tweeted on Twitter, so please follow the CAMH Nicotine Dependence Service at PS Quit Smoking. And to follow the live tweeting or post your own questions, you can follow the hashtag webinar. So I'm just going to, before Dr. Selby comes in, I'm just going to do a brief bio of him. Dr. Peter Selby is the Director of Medical Education and a clinician scientist at the Center for Addiction and Mental Health. He is the Executive Director and creator of the TEACH project, and his research as a principal investigator at the Ontario Tobacco Research Unit includes smoking cessation, especially in smokers with comorbid conditions. Here are disclosures for Dr. Selby, and here are our disclosures. The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care, and content of slides are primarily based on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussions, set out only general principles and do not replace the need for individualized clinical assessment and treatment plans by healthcare professionals. So before we get started, we're just going to do a few poll questions just to sort of gauge who's joined us here today. So in a second, just using your computer or the chat box, just indicate what your current discipline is. And you may need to scroll down to see all the options. So just looking off of this, it looks like most of us here today are registered nurses. Awesome. Next, just indicate which of the following you work for. Again, just using your computer or typing it in. And it looks like today most of you are from family health teams and public health units. And finally, again using your computer, please indicate what region your organization serves. They're jumping a bit. So it looks like most of you are from the Southwest area and the Greater Toronto area. Perfect. Okay, so that's all from me. I'm going to hand it over to Dr. Selby now. So intro.
Thank you, and good afternoon, everybody. Welcome to this summer webinar. I'm surprised that we have so many people who've joined in today, but we're very pleased. And what the objectives of today's webinar is to go over what the impact of having a mood disorder or mood problems on smoking cessation, what does that do to people, and understand what the PHQ-9, which is a questionnaire, validated questionnaire screening tool for depression, and how do you use that when we're dealing with people who are trying to quit smoking, and then tailor brief interventions to address mild depression as a barrier to cessation success. Because as we know, for the most part, we're going to see obviously people with severe depression don't need a screening test to figure out that they're severely depressed. But it's usually the mild to moderate that we tend to miss, and so that's what we're going to try to talk about today. So looking forward to your participation as we go along. We really like the fact that people are using the chat feature, so please keep typing away, and that side questions as they come along, and I'll get to them either during the talk or just after, at the end during question period. So just feel free to type as thoughts come to mind. So I'd like to start off with a fictitious case of Ayesha, but it's a composite from what we've seen in looking at the stop data, especially in our primary care and other sites. So this is a typical woman who we would see is 55 years old. She came in at baseline, smokes 25 to 30 cigarettes a day. So that's a little bit more than a large pack. And reports no formal diagnosis of any chronic health conditions, no mental health issues or substance use disorders on the baseline. And basically has been, started obviously on the 21 milligram patch, didn't really do well, added another 7 milligrams, also getting gum as a breakthrough. And, it's the fourth visit, and really is reporting difficulty quitting, continues to smoke here and there, but also starts saying, I'm feeling you notice that she's and says, I'm feeling sad, nervous, fatigued, not able to focus during the quit attempt, feeling kind of out of sorts. Talks about cigarettes as giving up to her best buddy. Those kinds of comments start coming to the fore. So what are some potential reasons why Ayesha is having trouble quitting? And please continue to type into the chat box, and I will try to see what thoughts you have. So I'll put the case up back again so that you get to see. So this is the fourth visit in somebody who's having difficulty quitting. Yeah. So so one way is that maybe the tobacco cigarettes are really helping deal with just emotions and feelings. Maybe that's possibly have a higher nicotine dependence, feeling discouraged because they're not able to stop. There may be environmental stresses. So we can start looking at them as what's happening biologically. So is this person having some biological issues, psychological issues, or environmental issues, and maybe more than one in one domain that is helping, that is causing her to have difficulty in quitting, possibly of an undiagnosed mental health condition, no support system, that's really the environment may not be, or a support where somebody's smoking in the home and continues to provide cigarettes. And there may be some biological determinants of this, that the person has stopped smoking. There may be some changes to the brain metabolism of various brain neurohormones and neurotransmitters such as dopamine, and that may be making her feel worse. Undiagnosed depression is another possibility, and again, may not have much else to do because now is sitting around bored and therefore is smoking. So clearly you'll have covered all the possibilities, and yes, you need to assess and explore all these these issues. And yeah, is she still currently smoking 25 cigarettes? Not really. She's brought it down, but not completely stopped, and so still struggling to stop completely. So I think those are the kinds of issues. I think collectively we've come up with all the other things, the issue around biological issues such as menopause, causing changes and maybe some biological changes going on as well at the same time are important to pay attention to. So clearly whenever we are faced with somebody who is at one level coming to the program, continues to try to quit smoking, and then is having difficulty stopping completely, we need to chunk it into, are there things going on in the environment that is making it hard to quit? Are there things going on sort of psychologically that is making it hard to quit? And lastly, is there something biologically going on that is making it hard to quit? And we're seeing examples of those three boxes. And so asking questions to find out before jumping to conclusions that this is because of something psychological or loss of motivation or anything like that, is think more broadly as to what could be going on. Again, that whole idea of identity as well being, so there's a psychological part. So all the questions all the responses are coming could be essentially classified under these three broad domains of something biological, psychological, or something in the environment. And the environment, I mean social environment, etc. as well. And clearly ways in which I think I can hear people are getting into is get the client's perspective or the patient's perspective as to what is the difficulties that they're having and why do you think they're having those difficulties. And sometimes there may be some clues there as to what's going on. And so sometimes that's a really great question when I can say, I notice that you've been really trying hard, you've been showing up for your appointments. What difficulties, what's coming in the way of your success? And that kind of question helps people sort of open up to you and tell you what kind of difficulties they may be having. And so that it doesn't just become an excuse, but they're really talking about what's going on. So one of the things we also do is check amongst all those questions is if you're using the STOP portal and you stop questions, there are validated questions in there like the PHQ-9. And when you look at this, Ayesha said no, she didn't get any counseling or problems for emotions or nerves or mental health. But if you ask some of the other questions around depression, anxiety, everything is a no. So, sometimes people are not willing to, they don't know they've been, have mild to moderate issues, or one of the other things that could be going on here is the person actually has feelings of depression, anxiety, and sadness as part of nicotine withdrawal. So it's also the other possibility is that you're not getting enough nicotine replacement. So you have to keep all these things in mind as you're going through systematically through it. So you look at the history given, there's no report of it or any formal diagnosis anyway. But when you take a look at the PHQ-9, which are the questions, over the past 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure in doing things. And then, you know what, I'm losing interest now. So you've got to figure out, was this before? Did this precede the, quitting smoking? But in the last 2 weeks, she was trying to quit smoking. So was this part of the withdrawal from quitting smoking or something else? Was she feeling down, depressed, or hopeless? So those are all sort of screening in questions that are coming in. And clearly, if there are these two questions that are endorsed of several days on either, then you're going to, it prompts to actually do the full questionnaire, which then tells us whether they're having other symptoms that would be suggestive of a mood disorder or depression, such as what we would call the, so the vegetative symptoms like difficulty falling or staying asleep, having tired or little energy, poor appetite or overeating. So these are all the vegetative symptoms. All are things that our body does, which are important for health, like sleep, energy, and feeling tired, are all important questions there. Then you're much more about the psychological symptoms about self, feeling bad about self or feeling a failure or feeling like guilt for no reason. Also starts coming in there. Trouble concentrating on things is important. And then speaking slowly, where other people have noticed and thoughts that you'd be better off dead. So that's really when it's getting more severe, and you can see that little eye there, that if anybody endorses that does require somebody to do a much more detailed examination. This is a quick and easy screening questionnaire that has been developed and validated and is an important one to look at, even if people don't endorse a diagnosis of depression. It's a hint that there may be something going on. So she does appear to report these depressive symptoms, and the question becomes, how do we ensure cases like Ayesha don't go unnoticed? Because I can tell you depression is quite prevalent in primary care and other settings, and people aren't always coming in with symptoms or complaining about the symptoms unless you actually screen for it. Because, if people are psychotic and are hearing voices, you don't need a screening instrument. They come in pretty bizarre, and they come in, telling you things like that. But with depression, a lot of times, especially in primary and community care, people are coming in like the walking wounded. They put on their brave face, they're out there, they seem to be coping, but it's only when you probe will you find out what's actually going on. And so sometimes they may even smile at you, and you would never say that person is depressed, but when you ask the question, it brings it out. So let's take a look at mood disorders, because generally you can take a look at the way our brain, the psychological functioning of our brain, the way we think, the way we feel, and what we do. Roughly, that's how you could think about it. So mood disorders really have to do with how we feel, and we can either feel good, or happy, or sad, or anxious, and or calm, right? So roughly, that's sort of all that encompasses sort of mood disorders. And you can also put in anger in there as well, which tends to go much more with depression and fear. So what are mood disorders? Mood disorders tend to be very severe and serious medical conditions that affect how people think, behave, and function. And as we said, they can go highs or lows. And essentially those highs and lows go on for longer than a couple of weeks at a time. So, for example, the highs would be, if it's a disorder, it would be bipolar disorder or manic episodes where you see people cycling from being very high to being very low. And then you have the lows, which happen in depression and bipolar disorders and anxiety. So that's a very quick overview. But depressive symptoms or feelings of sadness don't always become illnesses. People can have feelings of sadness which are normal, just having a bad day. That doesn't make you have a disorder. So when you take a look at that, you have to take a look at what's the range and for how long has this been going on. So 2 weeks is usually what is used in the patient health questionnaire, PHQ-9. And sometimes we use the PHQ-2, which are those 2 questions I showed you, as a short, really, really short screener. And if people are showing positive on that, you do the 7 additional questions. So people can have questions that go from no symptoms to minimal symptoms to having a depressive disorder with mild, moderate, or severe severity. And again, remember, these are screening instruments, so they tend to be more sensitive. So just because somebody scores positive, it's not diagnostic. Definitely this person has a diagnosis. The chances of them having a diagnosis is higher, but it needs to be assessed clinically. So what depressive symptoms are generally happening in Canada, and what are the symptoms that people in general are reporting, whether they use tobacco or not? 90% will talk about the depressive symptoms of losing their motivation. 80% will say they lose enjoyment of favorite activity. So, when you ask patients, you say, well, what's giving you pleasure nowadays? Are you able to have a good laugh? He says, no, I really don't like that anymore. I used to have a really good time when I went out to meet my friends, or I went on a run, or I watched TV, or I read a book. I just don't get pleasure from it anymore. There's a loss of that pleasure, that anhedonia. Concentration is a big one that gets affected. So you can ask questions like, are you able to read through a book, or does your mind wander? Are you able to focus on what you're reading, or do you have to keep rereading it, or does it take you a long time to finish what would normally take you a pretty short time? Are you feeling slowed down because your mind is wandering? So definitely concentration is an important one, and that's like 77% of people who have depression will report that. And feeling isolated. Isolation is a common problem, and it's a very common problem in people who smoke. If you look at the Framingham Heart Study, which was done, which looked at the risk factors for heart disease, now when you take a look at people who smoke, they're isolated in their communities. They tend to be much at the margins of society, and isolation tends to go along with smoking, but it also goes along with depression. So we have 3 million Canadians who have been affected by depression in their lifetime, and it's more common in women who endorse it than men, and it could be that the way men experience depression may be very different than how women experience depression. They may or may not endorse feelings of sadness or loneliness. They may endorse much more feelings of anger, except for example, and the tests don't really do that. So the highest appears to be in the youngest age group, and this could simply be a generational effect where people of a younger age may be more willing to endorse it than an older population, and so you're seeing that, but again, you're seeing this a higher prevalence now. It's still not crossing over the 10% mark, but I guess in the 15 to 24, you're seeing that it's going up higher than at least the 5% in both men and women. Women almost double that of men. And then you see a much more close prevalence in men and women in the elderly. So one of the things with depressive symptoms and smoking, they tend to go in the same patient, and they go hand in hand. So 18% of smokers have depression, will endorse depression in Canada, versus 8% of non-smokers will have depression in Canada. So they seem to go together. Now, why is this happening? There could be many reasons. So one is there's a shared reason. There's a shared determinants of why people are depressed and why they get smoked, whether it's a genetic factor or it's a environmental factor. That effect of that factor makes them want to smoke as well as makes them depressed. So, for example, when people are very anxious about say a situation in their community and they can't do anything about, they may get depressed, and they may also, because cigarettes are available, may also smoke because they're looking at something to do, for example, and makes them reach out for cigarettes. And so that is one sort of shared reason. The other issue is that when people do smoke, it may cause a bit of a bump in the dopamine release, which we know has to do with reward and pleasure, the final pathway for pleasure, orientation to pleasure, and that may be reduced in people who have depression, but the smoking may be increasing that. The other possibility is that when people's brains are depressed, they may be more sensitive to cues and cravings when they're depressed as opposed to when they're not depressed. So there may be, it's complex, it's not a simple answer as to, oh, well, because you're depressed you smoke, or because you smoke you'll get depressed. There's a complex interplay between these within these two conditions. But there is a significant difference in smokers with depression in Canada versus non-smokers with depression in Canada. And so there's about a 10% difference. Now, the other thing when we look at causes, so things may be associated, maybe they go together, but does one cause the other? And there does appear to be a dose-response relationship between smoking and depression. So when people are daily smokers, the depression is 11.84%, occasional smokers is 8%, it goes down to former smokers 5.3%, and never smokers 3.9%. And so this is pretty interesting that former smokers have a much lower rate of depression, and we'll come to that in a bit, because previously we may have thought that people were self-medicating their depression with cigarettes, but it could very well be possible the other way around, that the toxins, the brain toxins that are in cigarettes, may actually be making people's depression worse. So what does depression do to people's sort of life course of their tobacco use? And what happens is they tend to smoke more cigarettes a day, they smoke for a longer duration, and they have a greater addiction to nicotine. Taken together, basically their pack years of history tend to be longer, which means just by exposure, they're much more likely to end up with heart disease and cancer and lung disease. And if the depression is what is driving this, then we really need to pay attention to that depression, because that's coming in the way of helping somebody quit smoking, and we may need to do something more about it. And when we take a look at the general population, but then we take a look at our own data through STOP from Jan 2014 to April 16, and 32,000 people who've been through the STOP program, and looking at depression severity, 2.5% will have 5 to 9 minimal symptoms. So this is not usually coming into that idea of depression, but of the 5,000, daily smokers in STOP will report having these depression. So it's not an inconsequential number of people who actually have depressive symptoms while they're coming into STOP. Whether they're medicated or not, they're endorsing these depressive symptoms. And so you can see that, most of them are minor, but minor to moderate, and a few are with major. So that seems to be the trajectory and the way it seems to be playing out in STOP. But what we do know is that does have an impact on quitting. So taking a look at this link between depression symptoms and smoking cessation, what we do notice both in STOP and in the published literature is that people with depression have and who are also trying to quit smoking have less likely to be successful in achieving abstinence. They have lower self-efficacy in their ability to quit. They feel less confident in their ability to quit. They obviously have more dependence on cigarettes, tend to smoke more cigarettes a day. When they quit, they have more report a more significantly higher withdrawal severity. And when they quit, their mood really tanks when they're quitting. And again, if they go untreated, they have an increased risk of developing another depressive episode. And that has been shown in the past as well, that say somebody's had a past history of depression and is not on any medication, and they quit smoking and they don't get any help or support, they could land up with another major depressive episode because they've quit smoking and their brain chemistry hasn't picked up again. So it is something to pay attention to when people are trying to quit smoking for all those reasons. Now, of course, one common thing is, well, people have a mental health diagnosis, they're depressed. That's their only pleasure. Let's forget about them smoking. Let them continue to smoke. But again, we tend to then have this therapeutic nihilism. We say we tend not to bother them, and we don't want to make them feel worse. So what we do is don't pay attention to them. However, many smoking cessation studies are showing that actually when people with depression quit, if they are able to remain abstinent, their depressive symptoms actually get better. Their mood improves. And the interesting thing is that many people with depression want to quit, although there may be a perception that they don't. So if you don't ask, you won't know. And even if you ask, if you don't motivate, they won't try. So, 47% of Ontario smokers with a mood disorder will make a quit attempt. So that in a one-year period. So it's not something that we should just ignore. We need to in fact pay more attention to them because they are interested in. At least half of them are trying to make a quit attempt. Now here we have a video which is available on YouTube, and you can see the link below. Feel free to click it, but just in the interest of time, I won't go through it. But basically, I'll tell you what an overview is of these videos. It's really talking to patients and asking patients with mental health disorders, asking them about their experience with quitting smoking and the experience with healthcare providers helping them quit smoking. And it's quite compelling, actually, these patient stories about how many practitioners don't believe that these patients with mental health disorders would quit. And so that affects how we approach it. The other thing is, coming back to the start, when you take a look at quit rates, if people have even minimal depressive symptoms, you're getting a significantly lower rate of quitting, from 34% down to 28%. So you're building in a disparity. We have a disparity in this patient population if we don't pay attention to that. So you can see that if they have minimal symptoms, their quit rate is about 28%, but if they have no depressive symptoms at all, it's 34%. So 6% difference between the groups. And so what that means is that there were 281 clients with minimal depression who are still in that follow-up. And so these clients continue to have increased risk of tobacco-related health effects because they're not quitting. And this includes, obviously, heart disease, cancers, and lung disease. And again, we know that both depression and smoking are risk factors for heart disease, so we need to pay attention to this patient population more closely. So, the trends of smoking cessation and how depression fits in, obviously there's been a gradual decline in smoking rates, but that has tapered in the last decade. So the slope has got asymptotic, which means the most people who have quit more than 5 to 10 years ago, and so we are in a steady state, and we really need to bring that down if you're going to try to get to 5% smoking prevalence by 2035 in Canada. We really need to think differently and help people, especially this patient population, who are likely to get left behind by helping them. So if depression, which is the most common mental health condition in Canada, and goes along with smoking, is a barrier, then can we integrate a way of managing the mood for the mild to moderate symptoms of depression into the cessation programming itself, because they are telling us that they are having some difficulties. So there's a lot of evidence actually for mood interventions to achieve cessation, and there's a Cochrane review, which is a methodology that looks at all the trials and adds the data together. This is from 24 trials, and what they find is that if you add a mood management intervention to smoking cessation programming, significantly increases the likelihood of quitting success. And so I'm going to quit again to see what happens to the slide, but I think we're missing something. There it is. Okay, so increased chance of successful smoking cessation with a psychosocial mood management intervention compared to standard care. So 47% in people who have current mood problems, if you do this, of increasing their successful being successful quitters. And it's a psychosocial mood management, so it doesn't involve providing medications or anything. It's just helping people manage their mood. And it's 41% in those with current or past depression. So even with people who've had current or past depression, doing the psychosocial mood management can make a big difference in their quit success. So again, let's go back to the polls. I mean, while you're answering this question, how confident are you in your ability? We will take a look at some of the questions that have come up as well. Okay, I think we've reached pretty much close to saturation. So I think we have 60% who are saying somewhat confident and about 30% not very confident. So, and we have 6% who are very confident. So that's great. Thank you. So before we go to the next slide, I will just pay attention to some of the questions that came up as well. With respect to depression by a life event, Kathleen is asking about depression by a life event trigger or general environment. Any comparisons to this? With this. Not sure yet, but generally whatever may precipitate a depressive episode is often not, I mean, people will can have a depressive episode with or without a life trigger event, and people can have life trigger events which don't necessarily lead to depressive episodes. They may get sad, they may be grieving or sad, but it's not to the point where it's meeting criteria for a depressive episode. So I don't know how, I mean, other than, obviously if people have grief and providing them, support for that, and if people have, time-limited situational stresses, helping them cope with that, clearly that helps because mood will improve, managing that. But if it's a depressive episode, it does need, depending on the severity, it will need help. What we're talking about in today's one is much more to the mild to moderate subclinical people who are not feeling, when they endorse, I'm not having as much pleasure, I'm not having as much fun. They don't really cross that score of 10 on that PHQ-9, but they're having some of the symptoms and it's interfering with their ability to quit. Karen asked, what happens if people have diagnosed depression and quit smoking and then doesn't take their prescribed medications? Generally, there is a higher likelihood. There's one study that has not been replicated but does show a higher risk of relapse to depression in that population who does that. And so we counsel them and monitor their mood over time. And again, if they are developing depression, we suggest that they get treatment for the depression, whether it's CBT or medication or both, rather than going back to smoking. And will it work for everybody who's trying to quit smoking? It's possible because people have, when you hear it and see what it's like, it's very simple. It's really about being mindful if you want to think about it. And so we need to think about whether mood management is a way for everybody as opposed to just that. So again, another question we want to get to is, what is your primary response when a client presents with depressive symptoms? Do you refer to a specialist or within the team? Provide counseling, provide education materials, do nothing, or you don't want to vote? So we've got like a neck and neck refer to specialist provide counseling group. It's like almost evenly split, and about 7% are providing education materials. And some, this is a bit of a false question in the sense that you could do more than one because it depends on what's going on with the patient. You may counsel some who are mild to moderate, and you may refer for those who are severe or suicidal. So I think, people are already typing in that they may do a little bit of all A, B, and C, and I think that's the ultimate answer, is that if you had to pick one, it just reflects what you do most often, but clearly, ideally, you should be doing all A, B, and C. So I'm just going to go forward to that. Next question. Okay. So one of the things is that we're going to continue to use the PHQ-2 and the PHQ-9 because it's been a well-adopted screening tool across. We've been using it for a while. You've been using it for a while, and it's a good tool to screen, diagnose, monitor, and measure depression severity. And also the full questionnaire can be used to guide practitioners as to what to do next, because the response options go from 0, 1, 2, or 3, and as I said, question 9 screens for suicidal ideation. So when you look at it, and the way it works in the STOP portal, it automatically calculates it, and we should be able to tell you, guide you as to what you need to do. So how to interpret them and decide the appropriate next steps is very simple. It's quite simple. If people have that 5 to 9 minimal depressive symptoms, providing that brief intervention and an education resource, which will be provided automatically via the STOP portal, will help manage that person. Because what we're trying to do is we want to make sure that people with depression have the same quit rate as people without depression. In our clinic here at CAMH, when we looked at patients who had PTSD, for example, versus those who didn't have PTSD, the quit rates were exactly the same. And it was because we adapted the intervention to make sure we are paying attention to that, and nobody's having a disparity in quit just because they have, the diagnosis. So we compensated, and I think by compensating, here's one way in which you can do it. So pay attention to the score, 5 to 9. Again, it'll be automatically via the STOP portal. 10 to 14, it's major depression of mild severity, and I know it's kind of confusing when you say major but mild. And clearly that brief intervention and educational resource, and you can see everybody gets that brief intervention education resource regardless of the severity. And then obviously if it's mild severity, you refer for psychotherapy or medication if appropriate. And that may be because of, in terms of how long they've had symptoms, or how impaired they are. And again, this is generally what is to be done, but again, this could be, depending on your setting, you may send them to the physician in your group or the nurse practitioner in your group who can take that full assessment and explore that further. They may provide the psychotherapy themselves or send them out for medication consultations. And again, generally, as the depression is getting more and more severe, you refer more out to specialty care. That's where medications are much more likely to be effective, either alone or in combination with pharmacotherapy. And so you can see that's generally how it goes. But it's really that if you notice that it's the mild depression and the minimal symptoms that could easily be managed within most primary care settings. So today's focus, we're going to get, there are 2 webinars on this. Today we're going to focus on the mild, minimal depressive symptoms, and major depression will be the focus of the second part of the webinar series. And so that's what the response would look like. And this is based on the published literature and what we found through the meta-analysis and others. Here's what it looks like to manage that brief intervention when somebody has a mood score. So one way is to take a look at the scores from that PHQ-9 and clarify. Say, I notice you've endorsed this, and so tell me a little bit more about the days that you're having difficulty enjoying yourself, or most days which you feel sad and blue, etc. And ask them, what link do you see between your smoking and your mood? And often people will say that, well, when I smoke, I feel a bit better for a while, and you just acknowledge, yeah, in the short term, people do feel better because they're feeling down, and having a cigarette helps, it boosts the mood. And it's complex because they may be coming out of withdrawal, or it may actually be giving them a bit of a hit or a buzz. Usually that's the first cigarette of the morning. And the other one is validate the client's feelings experienced during the cessation attempt. Some people will say to you, look, I'm fine, but when I quit smoking, I get really cranky, sad, tearful, irritable, and that becomes problematic for me. And sometimes, when you ask that before they make that quit attempt, that has really helped them understand that, yeah, it's not uncommon for people as part of withdrawal to have a bit of a dip in their mood. And so just validate that for them. Of course, you're going to do the readiness to change and say even with those symptoms, success is possible. Try to, again, encourage positive, healthy attitudes and activity. So clearly physical activity, we know, is a very important piece of this. So getting active, whether it's walking, running, whatever it might be, whatever they're capable or willing to do, physical activity is an important piece of this. And then really in sort of working with collaboratively and monitoring the mood and that's possible over the future visits that you're going to have with them. Understanding that they may need higher doses of nicotine replacement if they are unable to quit. So the language, again, is probably what you're already doing is being supportive. It isn't rocket science. And the main thing that seems to make the difference that comes out is tracking of the smoking, mood, and participation in activity. That's what the mood management is really about when people who have minimal to minimal depressive symptoms but are still scoring above 0 on the PHQ-9. So when you have that, really it's exploring what they see as the link between mood and smoking, and validate that it might dip when they quit because of withdrawal, but it'll pass. Help them when you're assessing their readiness. Often these people say, yeah, it's important, but I'm not that confident, primarily because they're worried about mood, and therefore providing supportive encouragement, exploring their fears and worries, providing support, and getting activities, inviting them to get involved in healthy activities is important, and then really getting them to track is a critical way of quitting. And in addition to tracking their smoking, tracking their mood and activity participation. So let's look at Ayesha again, review the PHQ-9 response, and again, this score and interpretation will be provided by the portal. PHQ-9 score of 8 indicates minimal depressive symptoms, so she doesn't have a diagnosis of depression. There's no indication of suicidal ideation or severe functional impairment, so you don't have to create a crisis plan for this person. And if you explore it, essentially this is, I ask openly, how is your mood coming in the way of you quitting? What do you think your mood's coming in? And is there anything else? And so it helps me hone down what's the barrier here. And so once we do that, then we can provide the resources, and there'll be the Stop Portal Resources tab, which provides a brief intervention and an educational resource for the patient. So what does that look like? It describes that link between mood-related information she provided and smoking. It'll help measure your readiness to change and enhance ability to quit. And then explore what healthy activities she enjoys and encourage participation in those activities. And again, how to use a tracking sheet, and that's the educational response. All of this will be available in the Stop portal. So sometimes people, as you know, are not ready to set a full quit date. They're willing to do a reduce to stop. So clearly using the NRT as a way for pre-cessation quit, in addition to what are some of the other activities that she's willing to do that are helpful. So whether it's getting out of bed every morning, making the bed and going for a walk, whether it's walking the pet, whether it's going to the gym, however much they're willing to do, that's in concrete, measurable behavioral terms is important, and how many cigarettes are they going to cut down by before the next visit. So it's not just leaving it very loosey-goosey, but it's actually having some concrete plans for her to follow with you. If people have know about the readiness ruler, so this is, again, part of the assessment. You've seen this in TEACH, and it really is a composite of the importance and confidence question that is being there, and so there you've got that as an available resource. This is from the published data from Munoz et al., and what is really fascinating to me is that these studies were done 20 years ago. 20 years ago, we knew that adding a mood management to smoking cessation to do that. And so there are sample tracking sheets. So there's the daily tracking sheet, and it also tracks, as I said, you need to not just track the negative behaviors, but track participation in positive activities, whatever those daily pleasant activities were. Look at that, what they did, monitor their mood and the number of cigarettes smoked. And again, this will be adapted for the STOP program. And clearly, I'm hearing people who are not as part of the STOP portal on the Stop on the Road. We will certainly look into that as to how to make that work. Okay. So that's an overview of why major depression or depressive symptoms are important in STOP, because we know that it's affecting people's ability to quit. It's triangulating with what we are seeing in the general population. And the patient, as we know in the STOP overall data set, 50% of people have endorsed a mental health diagnosis. And this is in primary and community care. So we know our current smokers you are reaching through STOP are not just a word well. You're getting to the poor smoker who has at least one other diagnosis, and most often it's a mental health diagnosis, most often it's depression. And it's getting them to have a reduced quit rate. And given the multiplicative potential effects from smoking plus depression on heart health, with heart disease being the #1 cause of death in Canada, we thought it would be important for us to start paying attention to this, and therefore we did the literature review, found what is possible, and found what we could do to help you manage, identify, and start addressing that. So we started off with the mild, minimal symptoms group that could get some brief intervention and brief advice of how to do it. And the future TEACH webinar will provide detailed guidance on the exact details of the brief intervention delivery. Just wanted to give you an overview today. A special focus on major depression, and we are hoping to integrate this and launch all of this in sort of better detail in the fall and winter of this year. But we just wanted to give you a heads up, get some feedback from you as to what you see, whether this makes sense to you, and we'll open up for questions and comments. So I like Kathleen's comment, which says, "Yay, read next steps." So good, those are the next steps. So we didn't want to. There was too much to go through in today. We just want to give you an overview of the current state and what our thinking is and where we are at. So please provide comments, concerns, questions. We'll open it up. Yeah, so there are studies of tobacco leading to risk of depression, and there's a great meta-analysis that has even looked at what is the effect of quitting smoking on people's depression. And this study, which comes out of Anne McNeil's group in Nottingham and was published a few years ago, suggests that, pay very close attention to this, that the effect size, that means the impact of quitting smoking on somebody's mood, in general, when you take a look at all the studies, is the same. The effectiveness is the same as adding an antidepressant to that person's treatment. So by getting rid of all those chemicals from somebody's brain from smoke has the same effect in improving their mood and their depression as actually prescribing an antidepressant. So often with my patients with depression, I'm often telling them, look, if you quit smoking, your mood is going to get much better. You're not going to get in and out of withdrawal. You're not going to get in and out of this toxic effects of the cigarettes and all the other chemicals that are in cigarette smoke that are making your mood worse. So, but it takes a lot of convincing because what happens is people say, well, when I'm feeling low and down, I have a cigarette and I feel better. Often what is happening is people are actually getting themselves out of withdrawal, and that's why they're having that benefit. They actually, because as you know, nicotine withdrawal, nicotine only lasts in the system about 90 minutes, a half-life of 90 minutes. So when they're going into withdrawal, they feel anxious, depressed, sad, and they have the cigarette, they get that little bit of a rush and boost. That makes them feel good, and they say, well, I'm feeling better, so therefore it's helping my depression. So, and when I don't have it, I get really depressed and sad. So that's why it really takes a lot of education and convincing of patients or clients for them to understand this relationship. The Anne McNeil study, I'm going to ask one of us to post it. I don't know if you can pull that up and send it out now, or if you have the link, or we can send it later. But that's there. And okay, what else is happening? So CBT, of course. CBT, as you know, is a very important, cognitive behavioral therapy is extremely important, validated treatment for depression, for smoking, for alcohol, for a whole anxiety, for a whole host of behaviors. And more now, there's a greater move to have something known as transdiagnostic CBT. So CBT for people, no matter what the diagnosis, but CBT works. CBT also works for sleep. So clearly, once you have people who are motivated to engage in treatment, providing CBT can be very helpful if you can take the principle of CBT and apply it to that behavior, whatever that behavior might be, including smoking, including depression. And I think we've got this other question. The visits are longer in patients who have mood problem, and it's not sure if it's necessarily beneficial. And clearly, if we're just, when we understand with people with mood problems, often they're looking at the world with gray-colored glasses. Everything looks kind of doom and gloom, and so it's part of what happens with depression. And so you do need to have some modification. Sometimes sessions may need to be slowed down. Their concentration is poor. Their ability to do stuff is poor. They may appear less motivated. But it's not because they don't necessarily want to. They just have that difficulty with the motor aspects of the depression and more physically manifestations of the depression. So sometimes patience is required, but for the most part with mild depression you don't see that. These slides will be made available for download, and this webinar is being recorded, so don't worry about that. What else? What other questions came up? We're going to share the study with you. CBT we talked about. And low anxiety after they quit smoking is a very well-known issue, because if you look at the symptoms of nicotine withdrawal, anxiety is a number one symptom that disappears after they have a cigarette. But that anxiety actually is caused by withdrawal, subtle withdrawal, and when they smoke, that withdrawal goes away. So they always think that cigarette smoking is actually making the anxiety less, but actually, if you ask them how anxious they are they able to go to bed without knowing where their cigarettes are? They're anxious all the time, actually. And many patients will report if they quit, if they get onto the other side, they'll say a couple of things. I can't believe how calm I am. I thought I'd be way more anxious, but actually I'm calm. As long as that person's withdrawal is managed in that first 7 days, they will actually then thank you because the anxiety is a lot lower. Sandy, very nice. Thank you for your kind words. Let's take a look at what other questions we have coming up. Yeah, so severe anxiety, that's the issue. So sometimes with severe anxiety, what we have to do is help them make sort of learning coping skills. So often I'm teaching my patients with severe anxiety the box breathing, and I often will identify for them, for example, when they smoke and they go take a smoke, they're taking a deep breath in, they're holding it in, and then they're letting it out, and they're repeating that. So that box breathing, so taking a breath in for 4, holding it for 4, letting it out for 4, or 5 or 6, or whatever they can tolerate, and going in that pattern of a box, right? So you take in, you hold, you let out, and you hold again is the shape of a box. That kind of breathing is associated with, just if the people repeat that, even without the cigarette, or if they want to have something in their hand, a straw, a long enough straw that they don't choke on, can help them just get that calming effect of breathing. And so so it really helps that anxious person learn that skill set. Learning a little bit of relaxation techniques if they don't have significant trauma histories are very important. And then adequate nicotine replacement is important. With the really anxious patients, I ask them a very important question. What is your worst fear of quitting smoking? What's the worst thing that will happen? And what that does is it brings all those sort of unspoken fears, makes them cognitively aware of it. And often when they say, well, I don't know what I'm really afraid of, and because I say, cigarettes are not becoming obsolete. It's not like there'll never be another cigarette available ever. So what's the worst that will happen? You'll have a cigarette. And sometimes when people have that sort of understanding that fear is just a way that the addiction is keeping them going, they start now being able to be much more calmer and much more willing to engage in cessation behaviors because they realize that fear is unfounded. So we put it up the link to the paper. So take a look at that. And what else? Yeah, so that's the paper up there. And I hope this has been helpful. So we want to keep you prepped for webinar 2. But this is just to give you an idea that we felt it was kind of not very appropriate for us to leave our patients who are having these mood disorders, who are coming to you in the real world, and are not doing as well because we are not giving them the basics of how to manage their mood. So people are saying thank you, and I want to thank everybody, and I want to thank my team for putting this all together. And I do hope you have a wonderful rest of summer, and hopefully you got to enjoy that eclipse for yesterday. And we'll see you again. So thank you.
Thank you, Dr. Selby, for that wonderful presentation. Before you all head out, just some few housekeeping details. So remember that if you are looking for a letter of completion from today's webinar, I will be posting a link to the evaluation and post-learning assessment, and you will have 1 week to complete that. As well, if you participated as a group today or you called in via teleconference, please make sure to email at teach@camh.ca with a list of the participants by 2 p.m. today. As well, our next Teach Educational Rounds webinar will be held on Wednesday, September 20th with presenter Megan Barker, focusing on It's Time, an Inuit-specific toolkit for tobacco cessation. And this is basically a new resource that the team has been working on over the past year, and this webinar will kind of explain its official launch. So registration is opening soon. And finally, if you missed the beginning of today's presentation, you want to view it again, or you're interested in seeing previous Teach webinars, you can view this as well as other archived webinars following the link below on our website. So again, we thank you all for joining us here today, and as Dr. Selby said, we hope you enjoy the rest of your summer. Bye.